quiet down. We're going to get started. We are delighted to have Dr. Lynn Kutel with us today. She's a professor of pediatrics in the Division of Pulmonary Medicine, and she'll be talking to you today about cystic fibrosis.
All right, can you hear me in the back? Yes, okay. So we're going to do this relatively quickly. Wait, where's my mouse? Make sure this guy's working. So I'm going to sort of speed talk because we have a lot to get through. And I'm going to start by saying that, as you can see, I am a pediatrician. I'm trained as a pediatric pulmonologist. But as you see on this slide, we have an adult and a child on it, and that's really for a reason. So cystic fibrosis, when I trained, was a pediatric disease. Adult physicians never knew about it, never saw a patient with it, because the average life expectancy of a child during my training was about 12 years of age. Is this too loud, actually, or no? It's reverberating for me. And at this point, 50% of our patients are actually over the age of 21. So it really has become a pediatric and an adult disease. So that's why I have both of those. So what we're going to do is we're going to start talking a little bit about the epidemiology of cystic fibrosis, the pathophysiology and genetics, the clinical presentation, a little bit about screening and diagnostic assessment, CF-related lung disease, and then the pathogens that are really specific to cystic fibrosis. And we're going to end up talking about therapy. When I talk about therapy, what I really want to do is, as we go through this talk, really have each thing sort of flow into the next, so that you really understand how our increased understanding about pathophysiology has helped us learn more about what I've always known really about some of the clinical presentations, and explained things that we never really understood about clinical presentations, and how that really relates to therapy. So I always joke that when I was training, we always used to say that most of our therapy was really based in witchcraft, and very little of it was based in science. And as we have learned more about the pathophysiology, more about the genetics of cystic fibrosis, our therapy really has moved into, a lot of it is really scientifically based now, which is sort of a good thing, obviously. So what is cystic fibrosis? It is a chronic, progressive, and life-limiting autosomal recessive genetic disease characterized by chronic respiratory disease, pancreatic insufficiency, elevated sweat electrolytes, and male infertility. And the salt shaker here is just to remind everybody that the basic defect in cystic fibrosis, as we will talk about in a few minutes, is a defect in the transport of salt and water. So CF is not a new disease. It was actually first described in German literature in about the 1700s. And what this quote says is, "Woe is the child who tastes salty from a kiss on the brow, for he is cursed and soon must die." So it was recognized many, many years ago that children who tasted salty, that there was something wrong with them. Although they thought these children were cursed, they didn't realize that they had a genetic disease. And CF actually was not identified as a disease entity until about the 1930s by Dorothy Anderson, who was a pathologist here at Columbia in Choney, what was then called Babies Hospital. Dr. Anderson, just, oh, by the way, was the great niece of the writer Hans Christian Andersen. And she was a pathologist who, and as everybody in this room knows, summers in New York can be really, really brutal. And there were a series of babies that presented to the emergency room at Babies Hospital who were dead from dehydration. And when Dr. Anderson did her autopsies, what she found was very typical findings of this shriveled fibrotic pancreas. And she wrote the very first papers called Mucoviscoidosis of the pancreas, which are the beginning papers that describe cystic fibrosis. And a lot of the original work in cystic fibrosis was actually done at Babies Hospital. So we're going to switch now, talk a little bit about the pathophysiology and really the genetics and sort of how that leads up to the pathophysiology. So as I mentioned before, it's an autosomal recessive genetic disorder. Over 2,000 mutations have been found on the CF gene. The CF gene is called cystic fibrosis transmembrane regulator, which is a malfunctioning CF transmembrane conductance regulator. CFTR is a glycoprotein that regulates gating function of salt and water in every mucus-secreting gland in the body. So although we're teaching CF in pulmonary physiology, that is only because the primary organ that's affected and the organ that causes the most morbidity and mortality is the lungs. But it's very important to remember that CF is a multi-system disease that affects all mucus-secreting glands in the body. What's also important for you to remember as we move along is CFTR may be non-functional or may have limited function. That's a really important fact because as we talk more about cystic fibrosis and we think more about the clinical findings and we move into therapy, that concept of completely absent CFTR versus partially functioning CFTR really comes into play. And I'll show you some cartoons in a minute, but just to describe it, when you have an abnormal CFTR, that leads to reduced airway surface liquid and impaired mucociliary clearance. The other thing that happens as a result is that routine clearance of the pathogens from the lungs is compromised. Remember, your lungs are not sterile. They're exposed to the environment all the time. But we have a mechanism in place so that we're not chronically getting lung infections. And in CFTR, in cystic fibrosis, where you have this imbalance of salt and water clearance and mucociliary clearance is impaired, you begin to see the development of abnormal pathogens in the airways. As a result, patients are at risk for repeated pulmonary infections, and that also leads to an exaggerated inflammatory response. This slide just demonstrates to you, again to remind you, that it's a multi-system disease. We think about the lungs and the sinuses as the primary culprits, but patients with cystic fibrosis, all of us have mucus-secreting glands all over our bodies, so the other organs that are affected are the GI system, and the reproductive system. So just go back a little bit, talk a little bit more detail about the genetics. CF is the most common lethal genetic disease in Caucasians. It is also seen in non-Caucasians. When I was trained, again, we were really taught that cystic fibrosis was a white disease. It's absolutely not true. We do see it in other non-Caucasian populations, although in smaller frequencies. There are 30,000 affected individuals in the United States and 27,000 people in Europe. 1 in 25, or about 1 in 30 Caucasians carries the gene for CF. So if you look around this room, guarantee you several of us carry the gene for cystic fibrosis, and we don't even know it. Just to reiterate, CFTR is a cyclic AMP-regulated chloride channel located in the apical membrane of glandular epithelium. It is coded on the long arm of chromosome number 7, and as I mentioned, there are over 2,000 mutations that have been identified. Delta 508 is the most common mutation. That is a missing phenylalanine at the 508 locus. And there are what we call class defects in CFTR, which I think that's not the next slide. So the next slide really just shows us the normal flow of genetic information and how that results in a full-length protein production. So what you have here is the amino acid. It's being read by the mRNA. And normally there's a stop codon that allows for some reconfiguration. And at the end of the day, you get a full-functioning, full-length protein. This is what normally should happen. But what happens in the production of CFTR in patients with cystic fibrosis is that this system can have a glitch somewhere along the way. And the best way to sort of think about it is an assembly line. So if I'm making a car and my assembly line sort of starts with a motor, and then we put the chassis, we put the frame around it, we put the muffler, we put the ignition system and all of those things. Depending upon where the problem occurs on the assembly line will determine how functional or non-functional my car is. So if I have a car where, in the very beginning, the motor is no good, that car is never going to get off the assembly line. If I have a car that gets off the assembly line, but let's say the ignition system isn't great, it may work, but it may not work really well. And that's exactly what we now understand happens in CFTR. So again, here is my cartoon, which really, this is probably one of the most important slides of this lecture. And so if we think about our airway epithelium, and you think about, we've got the airway surface area, so the lumen of your airway, and then you have the interstitial space. So normally what should happen is you have CFTR, and if you think about CFTR, it's really like a gate. It's a channel. It's allowing salt and water to go in and out of the airway. You also have what are called ENaC channels, which are responsible for the transport of sodium. So under normal conditions, CFTR and ENaC activity results in healthy airway surface fluid layer and normal mucociliary clearance. which means that chloride can go in and out of this channel, water can go in and out as needed, and sodium can also go in and out of the ENaC channels. And if you think about the analogy of a bag of potato chips, if I eat a bag of potato chips, what happens afterwards? I want to drink water. And I want to do that to maintain normal hydration. And wherever chloride goes, sodium wants to follow. So in a normal airway, you really have this very nice homeostasis of sodium, chloride, and water, so that your airway surface fluid is very thin, very watery, and you can clear secretions, you can clear pathogens, and life is great. But in cystic fibrosis, CFTR may be present, but it may not work. It may not work at all, or it may have partial function. And as a result of the failure of CFTR to transport chloride, you actually also get an overreaction of ENaC. And so you get more sodium pulled into the interstitial space. Chloride actually can't get out into this airway, and you get this very, very thick, dehydrated mucus that becomes static. It sort of paralyzes the cilia. So you get this dehydrated airway surface layer, and you have difficulty clearing airway secretions. And this sets the entire stage for cystic fibrosis. And again, as I'm showing you, this is an airway cell, but the same defect happens in the GI system, it happens in the sinuses, it happens in the reproductive system. So this next slide actually shows you the slide of these mutation classifications, which I mentioned before, this concept of an assembly line. The most common mutation is Delta 508, which is what we call a trafficking defect. CFTR never basically gets made. It sort of gets stuck. So again, if we think about a protein, it gets coded for in the nucleus, it goes to the ribosomes, it gets packaged up in the Golgi apparatus and the endoplasmic reticulum, and it gets shuttled up to the apical membrane. But in trafficking defects, such as Delta 508, it just never gets anywhere. So you have completely absent CFTR functioning. And that accounts for 87% of mutations in cystic fibrosis. We then have patients with less mild abnormalities in CFTR. These are called abnormal channel function, reduced synthesis of CFTR, or where you may have decreased stability of CFTR. Although these are less common, they're really, really important, because these are patients that we have learned. We used to always sort of see patients that we sort of thought had CF, we weren't sure they had it. Now we really understand that they do. They have non-classic CF, but they have taught us a lot about the functioning of CFTR. And with that understanding of CFTR, new therapies have been developed to really try to target the basic defect of cystic fibrosis. So if we drill down a little bit more, again, similar to that first cartoon that we saw, but this one shows a little bit more detail about really what's going on inside the patient. And again, understanding this is really important, because if you understand it, it makes sense. The therapies that, number one, we used to do thinking they just sort of made sense. Now we understand why they made sense. But it's also really allowed for development of new therapies. So again, we have your airway surface, the respiratory epithelium, your airway surface fluid with the cilia. You have CFTR over here. And again, CFTR isn't working well, so we don't have proper transport of chloride. We get more chloride and sodium in the interstitial space, this very, very thick, dehydrated airway surface fluid, with the development of a mucus plug. With that development of a mucus plug, you've got decreased mucociliary clearance. You begin to get bacteria that just sort of like to come sit there and hang out. They like the environment. This high salt, dehydrated environment is really conducive to the growth of bacteria. And as a result of that, we begin to get also the migration of inflammatory mediators into the airway. So this sets up a cycle of infection, inflammation, infection, and inflammation. So now we sort of have the basic background, and let's sort of switch over to the clinical presentation of cystic fibrosis. We will focus primarily on the pulmonary, but I will touch a little bit on the GI manifestations of CF. So what are the pulmonary signs and symptoms? Well, patients with CF have persistent cough, they have wheezing, shortness of breath, they develop ultimately bronchiectasis, they have frequent lung infections, and they have very thick, viscous secretions. This should sort of make sense based on what we talked about. We talked about the fact that they now have airways that aren't wide open, that they're just filled with bacteria, inflammatory mediators, and sputum. CF is really the prototype of a disease where the primary pathophysiology is ventilation perfusion abnormality. There's nothing wrong with the perfusion. It's really it's a VQ mismatch that these patients have. In terms of their GI symptoms, they develop pancreatic insufficiency, and they're also at risk of pancreatitis. Again, the pancreas is a mucus-secreting gland very early on in life, and actually in utero for most patients, the glands of the pancreas just become completely blocked up, and they don't make the enzymes that they need to absorb their food. This results in malabsorption and bowel obstruction. Babies may be born with what's called meconium ileus. It's an intestinal blockage, again, because the meconium is really thick and viscous as a result of this abnormality in secretions. This leads to poor growth and weight loss. As our patients get older, we have about 25% of them that are at risk for something called CFRD, or cystic fibrosis-related diabetes. It's a form of diabetes that's very specific to CF patients. It's very insulin sensitive and easy to manage, but it's purely related to the fact that they've sort of burnt out their pancreas. They also develop vitamin deficiencies, the fat-soluble vitamins. Because they don't make the enzymes that they need to absorb food, they don't have vitamins A, D, E, and K, which are the fat-soluble vitamins. So these are replaced on these patients early on. Other symptoms are that they have salty sweat, and we'll talk about that in a minute. They have sinus disease, as I mentioned before, so they may develop nasal polyps, sinusitis. They have clubbing of the fingers from their ongoing respiratory disease. And by and large, most men with cystic fibrosis are infertile because of a blockage of the vas deferens that also occurs in utero, again, because these very thick secretions block the vas deferens and scar it off really early on in life. So let's talk now about the sweat gland. I mentioned before in that very first slide that kids with cystic fibrosis taste salty. This is the slide that confuses the medical students the most every single year when I do it. So I'm going to go through it relatively quickly, but the take-home message here is the sweat gland is sort of like an inside-out respiratory gland, and that's really the way to think about it. So normally what happens when we sweat, we don't want to lose all the water in our body because otherwise we would become dehydrated. So when it gets warm out, which we hope will happen someday, we don't know when, and when we sweat, we put salt into our sweat glands, and then we have CFTR in our sweat glands, and CFTR's job is to reabsorb that chloride because we don't want to lose all the salt in our body, because if we lose all the salt in our body, we'll lose all the water, and we'll pass out on 168th Street from dehydration. So we absorb chloride, and with the chloride, what comes with it? Sodium and water. And so we basically reabsorb most of that fluid, and we don't lose a lot of salt and water in our sweat. That's what our body wants to do. But in cystic fibrosis, again, this is like an inside-out respiratory cell. The salt goes inside the sweat gland. CFTR is not working. We have this overexuberance of ENaC. And what happens is we basically don't reabsorb any of this chloride, and we end up pouring out all of this salt pouring out all of the salt, and water follows. And that's why Dorothy Anderson saw these babies that presented with dehydration and basically salt loss. So one of the ways that we diagnose patients with cystic fibrosis, and this is amazing, this was the pre-HIV era, but again, when I was a fellow, we licked every baby because kids with cystic fibrosis taste salty. And sometimes the parents will come in and they'll say, yeah, you know, Hugh Sheila's playing soccer, and you literally see beads of salt on their forehead. We don't lick them anymore. That we don't do. Okay. So how is the sweat test done? The sweat test actually was also developed here at Babies Hospital by Paul de Saint-Denis. Again, they recognized, he and Dr. Anderson saw that these babies tasted salty. There was something going on. And so what the sweat test does, it really was, up until about 15, 20 years ago, the only way that we could diagnose cystic fibrosis. It still is the gold standard of how we do it. And so because of this overexuberance of the sweat gland in cystic fibrosis, we can measure how much salt is in the sweat of a patient with cystic fibrosis. We use gauze that's embedded with pilocarpine to try to stimulate the sweat glands. And then you put that gauze down and you use a little meter to set up an electric charge. And that actually stimulates with the pilocarpine the sweat glands to produce sweat. We collect that sweat over about 45 minutes, and then that gauze goes to the laboratory. They elute the sweat, and they measure how much chloride is in the sweat. So a positive sweat test is when there are greater than 60 milliequivalents per liter of chloride in the sweat. A normal sweat test is when there are less than 40 milliequivalents per liter, and a borderline sweat test is when there's 40 to 60 milliequivalents. So this is interesting, again, when we go back to that sort of basic science that we talked about before, and I mentioned those patients who have sort of milder mutations where CFTR sort of works, but it isn't really, really perfect. So again, clinically for years, we would see these patients and we'd go like, I sort of feel like this guy's got CF, and he's got some lung disease, but he doesn't have the pancreatic insufficiency, and we'd sweat these people like 9, 10 times, and their sweat tests would come back 39, 42, 45. So in theory, we couldn't diagnose them because they didn't fit into that positive category of over 60. In the 1980s, when the first mutation for cystic fibrosis was found, we thought, oh, this is awesome. We found one mutation. We're done, finished. We didn't expect that we were going to find over 2,000 mutations for cystic fibrosis. But what we now understand is that those patients with sort of the variant or non-classic CF who have partial function of CFTR, those are the people who have those borderline sweat tests. They do indeed have cystic fibrosis. They just have this sort of non-classic form of cystic fibrosis, so they may not have all of the manifestations. They tend to have milder disease. The other thing that we have actually learned is over the last 10 years, we now do newborn screening, and we're now sweating little tiny babies. We're sweating babies as early as 2 to 3 weeks of age. And what we're finding is that the very young babies who we know have CF, because we know by their genetics that they have CF, their sweat tests are actually high. A positive sweat test in a newborn is actually a lower number than a positive sweat test in an older person. So I'll show you later on a slide, but a sweat test of about 30 to 40 in a newborn is actually considered to be positive. And the explanation for that is that the sweat gland in the newborn is actually immature. It doesn't have the same level of maturity as we see in older patients and adults. So this is my disgusting slide of the morning. And again, when I showed you before, sort of that slide, I said, this is like the most important slide. This is the other most important slide. This is the bottom line. This is what is clogging the airways. This is what is clogging the GI system. It's what's clogging the sinuses. And it's what's clogging the reproductive system. This is what is causing all of the clinical manifestations that we see in cystic fibrosis. If we look at it under a microscope, it looks like this. And again, as we've learned more, this stuff really makes sense. We see an airway that instead of being filled with air is filled with mucus and it's filled with neutrophils. It's difficult to breathe through this airway. You have a ventilation perfusion abnormality or mismatch. If we look at a gross pathologic specimen, this is what we see. We see the development of bronchiectasis. You have just recurrent, ongoing infections, ultimately leading to destruction of the airways with all these little sort of saccules. And here's an end-on airway, and you see it just completely filled with mucus. So this is sort of a summary of what we've talked about so far. We have an abnormal CFTR leading to reduced airway surface liquid, impaired mucociliary clearance, and then a cycle of airway obstruction, infection, inflammation, ultimately leading to structural damage, bronchiectasis, pulmonary insufficiency, respiratory failure, and death. So I've talked a lot about infections in cystic fibrosis, and one of the fun things about being a CF doc is you don't just do pulmonary medicine. You really have to do a little bit of infectious disease, a little bit of gastroenterology. You really get to do a lot of different things. And one of the interesting stories about CF is this concept of the infections that patients get with CF. So I mentioned before, I've mentioned a lot of times already, that the airway surface fluid has a different character. It is different salt content, it's really dehydrated, and it really becomes a nidus for infection. So what we see is there are a very typical pattern of infections in patients with cystic fibrosis. Early on, almost all babies are colonized, a very high rate of babies are colonized with H. influenza. Normally, when you do a sputum culture or a throat swab on a healthy person, you really get back a report that says mixed flora, because again, your lungs are not sterile, they're exposed to the environment all the time. But what we see is a fairly typical pattern. And so the young kids often have H. influenza. They may also have a fair amount of Staph aureus in their airways. But as they begin to get older, we see the emergence of Pseudomonas aeruginosa. So Pseudomonas aeruginosa is a ubiquitous organism. We're all exposed to it all the time. It is when you go across the street to a salad bar, the salad bar is teeming with Pseudomonas aeruginosa. When you go to a hot tub, the hot tub is teeming with Pseudomonas aeruginosa. When you leave lettuce in your refrigerator for too long, that slime that's on the lettuce, that's Pseudomonas aeruginosa. So we're all exposed to it all the time, but most of us don't get sick from it. I'm sorry. It's early in the morning. But what happens in people with CF is that again, because of this change in the environment of the airways, the Pseudomonas actually takes hold and it becomes a pathogen. And it's really the primary organism that we are concerned about and that we target in fighting pulmonary infections with cystic fibrosis. We also see, and some of this is really a moving target. Again, as I mentioned before, the average life expectancy untreated of CF is about 6 years of age. In today's day and age, the median life expectancy is about 38 or 39 years of age. And as our patients live longer, we're learning a lot more about the natural history of this disease in older people, which we didn't really know 15, 20 years ago. In addition, our patients are living longer, so they're under a lot of antibiotic pressure because we're treating them with antibiotics all the time. And we're seeing emergence of new pathogens. So we never really know 100%, is this just part and parcel of the disease, or is it really part of sort of the treatment pressure and that's sort of our measure of success? So we know for sure that Pseudomonas really is part of the normal pathology because that's really been, we've seen that since the very beginning. What we are now seeing, though, which is interesting, is the emergence of a lot of MRSA in our patients. There are some centers that have 50% of their patients colonized with MRSA, and it's really not clear whether that is part of the natural disease process or really that's more antibiotic pressure from all of the therapies that we've seen. We also see other diseases, other organisms such as Stenotrophomonas multifida, Achromobacter, as well as Burkholderia cepacia complex. Some of these, especially cepacia, for example, are really very toxic, and patients can become quite sick very rapidly from them. Let's talk a little bit about the natural history of Pseudomonas. And this is important because it has a lot to do with how we treat patients. So we think about the lung at birth being sterile. And then somewhere along the line, patients have what we begin to call intermittent infections, where every once in a while we see Pseudomonas growing out of their sputum. So years ago, we used to just sort of like say, oh, okay, they've got Pseudomonas. We used to never do anything about it. What we now know, because we have a very extensive national registry of all CF patients, is it's better to be Pseudomonas aeruginosa negative than to be Pseudomonas aeruginosa positive. There is at least a 5-year survival advantage if you're Pseudomonas negative. So what we now do is we're very aggressive in treating what we call these intermittent infections. One, because we know that it's better to be Pseudomonas negative, but also because what we have learned is the organism actually is really quite amazing. Pseudomonas has an ability to morph itself, to make a little coat of armor around itself so it becomes impermeable to antibiotics. And these very early infections are actually very sensitive to antibiotics, and we have a good shot of eradicating them. And the longer we can keep patients Pseudomonas-free, the better. We then begin to see persistently positive cultures, and that's a period that we call chronic infection. And then over time, the Pseudomonas becomes mucoid, which is what I just referred to, this concept that it has this ability to sort of make a coat of armor, to excrete a mucoid sheath around itself, and actually also to live in these like biofilm communities. It can actually arm together, and they can all live together and become really, really resistant to antibiotics. And I mentioned before that we try very aggressively to eradicate intermittent infection in those first isolates. But once the infections become chronic, what we then begin to see are what we call these pulmonary exacerbations, where the Pseudomonas sort of flourish. You get like a bloom of Pseudomonas, and the patients clinically become very sick from them. And that's really that's a time when we have to intervene. And the other thing that we really do now is this concept of chronic suppressive therapy, where we really try to give patients antibiotics all the time to try to keep the burden of Pseudomonas as low as we can. So what are the signs and symptoms of a pulmonary exacerbation? This should sort of make sense at this point. They have increased sputum production because there's this brisk inflammatory response. And if we look at the mucus of patients with cystic fibrosis, it's really just chock full of inflammatory mediators. They have decreased exercise tolerance because their airways are getting filled up with that thick mucus that I showed you. They may become increasingly short of breath. On exam, we'll see new findings such as rales or wheezes. Their FEV1 decreases, and we define a pulmonary exacerbation as a decline in FEV1 of 10%. They may or may not have new radiographic findings. And weight loss. Well, that's sort of interesting. Why is weight loss such a big thing? Well, you're sitting here, it's like 8:30 in the morning, 9:30 in the morning, everyone's a little brain dead, and you're not using a lot of your caloric intake to breathe. You're using like maybe, like 2% of your caloric intake really goes to your work of breathing. It's not very labor intensive to breathe. But if you've got cystic fibrosis and you are coughing all the time and you're fighting infection all the time, you actually can increase your caloric expenditure for your work of breathing up to about 14 or 15%. If you then add on to the fact that these are children and adolescents, where the caloric intake is just, the caloric requirements are massive. They're just massive. These patients can drop 10, 15 pounds really, really quickly when they have a pulmonary exacerbation because they're increasing their metabolic rate, they're working harder to breathe, they're fighting infection. They also don't feel well, so they don't really feel like eating, and they can really plummet their weight pretty quickly. That's very important for a few reasons, but the most important reason is that we have ample evidence that lung function is directly related to nutrition. So it is really important that we keep these patients' weight up and keep them in really good nutritional balance. And obviously the other signs and symptoms are they may not feel well enough to go to school or to work. So what happens with their lung function? Again, it's an obstructive lung disease. It's a ventilation perfusion issue. So what you see here are normal pulmonary function parameters. And what I want to point out here is, again, think of that mucus, think of the airways. This is an airway disease, and the very first thing that our patients lose is their FEF 25/75. Those very small airways get knocked out really early in the process by that thick mucus, even when the patients are basically almost completely asymptomatic. That's the first thing that we're going to see. The next thing we see is, again, it's an obstructive disease. We'll begin to see an increase in their RV over TLC. They're beginning to do some air trapping. And as the disease progresses, you'll see their FEV1 begins to drop out. Their FEF 25/75 just becomes almost non-existent. Vital capacity eventually will decrease. Their total lung capacity will keep on increasing as they begin to get more and more air trapping until they have end-stage disease, because they also get scarring of this tissue from recurrent infection. So at the end of the disease, you may begin to see their total lung capacity decrease, but that's really end-stage. Residual volume over TLC, again, is a measurement of air trapping and obstruction. Just keep on going way, 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 way up there. PO2 is initially really normal for a long time because and is initially normal and then begins to drop down. And the PCO2 actually stays normal until pretty late because, again, remember, you can actually correct for your PCO2 pretty easily by just increasing your respiratory rate to blow off your PCO2. So it's not until these patients really, again, have pretty advanced disease that they begin to retain PCO2. So I'm going to show you two x-rays. The first is on the left is somebody with mild disease, and the one on the right is somebody with more advanced disease and bronchiectasis. In early disease, it doesn't really look any different than a kid coming into the emergency room with a bad viral infection, with bronchiolitis or something like that. You really just sort of see increased markings and hyperinflation. So you see these diaphragms that are a little bit flatter, and you see airways that look a little bit hyperinflated. But with advanced disease, you see this very marked hyperinflation, and you begin to appreciate the bronchiectasis. So I don't know, x-rays always show up really poorly, but here you begin to see what we call like cysts and nodules. So these are end-on airways that are thickened because of that recurrent infection. So here's like a little cyst, that's bronchiectasis. And then every once in a while, like here, here's better, you can catch these nodules. That's that end-on airway that I showed you before that's impacted with mucus. A better picture is this. And this CT is a little bit misleading because you see very one-sided disease, but generally CF is a diffuse disease. But here you can really appreciate this unbelievably extensive bronchiectasis. What's very different about cystic fibrosis than a lot of the other diseases that you're going to study is it happens gradually. You know, this process starts from the time kids are born, and so they really adapt to it. It's not like they're healthy for like 25 years and then suddenly they get a disease. It's also a diffuse process. It sort of happens, it may do something like this, but what's amazing is that this person actually had normal lung function. And that's really, really dramatic. They're able to sort of compensate a little bit because it is so gradual for them. So we're going to briefly talk about some of the complications. I'm not going to spend a lot of time, but because of these recurrent infections, patients with CF can develop hemoptysis and cough up blood. It's probably the only thing in CF that's really dramatic that happens. Everything else in CF is pretty gradual. The other dramatic thing they can do is they can get bleb formation, again, because of this chronic obstruction and air trapping, and they can pop a pneumothorax, which just shows a patient with blebs in their chest tube in. Let's go to the next one. I mentioned clubbing before, so it is a chronic lung disease, and slowly over time, all of our patients develop clubbing, which is thought to be due to periosteal new bone formation underneath the nail beds. What I want to do now is start talk a little bit, spend the rest of the time, and I'm going to really go fast because we're going to run out of time otherwise, talking about therapies and this concept of exacerbations and how we approach the treatment of cystic fibrosis. So I mentioned before that these patients have exacerbations, and so what this slide shows is everybody sort of starts with normal lung function, and we think that everybody with CF loses about 2% of their lung function a year. And every time they have one of these exacerbations, they can drop about 10%, and then our goal is to try to get them back to what they were and to sort of slow this progression. So how do we do that? CF care is given in CF centers with multidisciplinary care. They're seen at CF centers about 4 times a year, and their care includes airway clearance, and we'll go through each one of these things, but they sort of make sense to you now. Like, you want to get that mucus out of there. We want to thin the mucus. We want to give them antibiotics to fight the infection. We want to try to approach that inflammatory response. And the newest, most exciting thing are these concepts of what we call CFTR potentiators and correctors, which many of you may have heard about. They've been in the news a lot lately. So airway clearance, the most basic, simple thing. This goes back to what we used to talk about witchcraft. We sort of thought it made sense. We didn't really understand why it does. And it's the same thing as the ketchup bottle. When you take a ketchup bottle and you turn it upside down and the ketchup doesn't come out, what do you do to the ketchup bottle? You smack it. Why do you smack it? What are you doing scientifically? You're actually breaking the bonds, the surface adherence of that ketchup to the walls of the ketchup bottle. That's exactly what we're doing to our patients. We are trying to bang that mucus out. It has increased surface tension because it's so thick. So if we smack it, we vibrate them, all those different things, we can help them expectorate their mucus. That is done a multitude of ways. It's done with just old-fashioned, what we call manual percussion, where we bang on their chest. And we also have a whole series of things called vests, which try to vibrate them and sort of help them cough it out. And then more recently, something called a flutter or an acapella, which is sort of interesting because it really speaks to our understanding of what's going on. What happens is this is like a little pipe with a ball. You take a big breath into total lung capacity, and very slowly you come down to residual volume like this, breathing in and out of this thing. And what it does, that ball bounces up and down, and when it bounces up and down, it sends back vibrating waves to help dislodge that mucus. Well, mucolytic agents make sense, right? You want to just like thin that stuff to get it out. It's sort of like cleaning a drain. So the 2 drugs that we have for that are what's called recombinant DNase, or pulmozyme, and hypertonic saline. So DNase is interesting because I keep talking about inflammation and talking about the fact that when you look at that mucus, there's lots of inflammatory mediators in the mucus. And those inflammatory mediators, there's lots of neutrophils that have come in to try to clean up that infection. When the neutrophils degrade, they leave behind their intranuclear DNA. DNA is that, remember what it looks like? It's that helix. That causes a lot of the viscosity of mucus in cystic fibrosis patients. So what recombinant DNase does is it actually breaks down the bonds of that neutrophilic DNA and makes the mucus, instead of being a very thick thing, more of a free-flowing liquid. And then finally, hypertonic saline, which is just basically hypertonic saline. And it really liquefies the secretions. Recombinant DNase costs about $10,000 a year. Hypertonic saline is pretty cheap. And I want to talk about the prices of some of these things so you understand really sort of what the investment is in taking care of these patients. We treat infections in every way we possibly can. I talked before about prophylactic treatment to try to prevent colonization. We also treat exacerbations when they happen, just to acutely try to get the patients better. And also, as I mentioned before, we treat patients for their first isolates to delay colonization. We give patients antibiotics every possible way that we can give it to them in industrial strength doses. So we give it to them orally, intravenously, but more recently, really for the last 10 or 15 years, we're able to give patients antibiotics by aerosol. And this has the advantage that we can give these industrial strength antibiotics that we want, so we can get very high concentrations into the airways with minimal systemic toxicity. We have two forms of, we have a form of aztreonam for inhalation and a form of tobramycin available for inhalation, and many more drugs in the pipeline that will hopefully be developed. And what this slide just quickly shows you is really the advantage. So what you see here is placebo given and inhaled tobramycin. And very, very quickly, over a 24-week period, patients have an improvement in their lung function. So the next thing we want to target is inflammation. And this has probably been one of the most challenging pieces of the puzzle for us. What's the best anti-inflammatory drug we know? Oral steroids. But we can't, this is a lifelong disease. And although there's some evidence that oral steroids may actually be beneficial, we can't give patients with cystic fibrosis oral steroids for 20, 30, 50 years of their life without very significant complications. And for some reason, inhaled steroids just don't seem to do the trick. And it may be that we just can't get the strength into the airways through these very viscous secretions. It doesn't seem to work. The other drugs that have been used are ibuprofen, which seems to have a very narrow window of efficacy for a small cohort of patients with cystic fibrosis, but it really has not been adopted in a very widespread fashion. The more interesting story is azithromycin. It ends up that many antibiotics work not because of their antimicrobial activity, but also because of their anti-inflammatory activity, and azithromycin is one of them. And so we actually give many patients with cystic fibrosis azithromycin 3 days a week, Monday, Wednesday, Friday, as an anti-inflammatory agent. That's very inexpensive. It's what we call a low-hanging fruit, really beneficial for many patients. So that's sort of how we treat patients basically. And what you can see here, this is a slide of one of my patients who came in. This is his flow volume curve. And you can see he comes in, he's got this sort of obstructive pattern to his PFTs. And this is when he comes in, his numbers are really low. This is week 1 of therapy, and this is week 2 of therapy. And generally, patients, when they're treated for an exacerbation, are treated for 2 weeks of very, very intensive therapy. The other thing that we're talking about really in the last 10 or 15 years is this concept of moving away from sort of doing acute crisis intervention to early chronic intervention. And the rationale for that is we don't want to wait until patients really have lost lung function. Bronchiectasis is basically irreversible. But if we begin to try to sort of start earlier on in life, we may have the ability to really just change this whole curve and sort of move it over to the right. We think about an FEV1 of 20% being a surrogate for death. And this is traditional intervention. We really didn't start doing things until people started to losing their lung function. And what we're now beginning to talk about more is this concept of mild disease intervention, really starting way, way, way before people are really in trouble. And more recently, to do what's called pre-FEV1 intervention. And we'll talk about that. So the last few slides, we talk a little bit about these CFTR correctors, which is this slide. So this is actually one of the most exciting things about CF in the last few years. Again, goes back to that thing, that assembly line. Yes, almost everybody with cystic fibrosis has delta 508, where there's almost no functional CFTR. But for some people with CF, CFTR really makes it into the apical membrane. There's a little bit of function. Those are the patients that have mild clinical presentations. Those are the patients that have those borderline sweats. So the concept behind these potentiators is that if we can turn those gates open, if we can open the door a little bit, maybe we can get that CFTR to function. So that's what we call a potentiator. It's increasing the opening or the gating of CFTR channels. And then there's the concept of correctors. So the idea of a corrector would be to almost chaperone CFTR through the process, through the endoplasmic reticulum, through the Golgi apparatus, and get it inserted into the apical membrane. And then, in theory, potentially, if you had a corrector, you might be able to use a potentiator, sort of this two-step concept, two-step prospect of sort of getting more CFTR activity. You don't need a lot of CFTR activity to basically be clinically functional. You need about 15 to 20%. So we don't need to have 100% of CFTR function. So this slide shows one of the original studies in these Vertex drugs. This is the drug VX-770, which is now called Kalydeco, or ivacaftor, which is the first Vertex product that was put on the market. And this is an unbelievable game changer. So if you look at FEV1, which is on this left panel, the blue are the placebo patients. This is an oral medication too, which is just amazing because our patients take so much other medication. And this is the FEV1 of the patients that were on VX-770. They had about a 10% improvement in their FEV1. Remarkable, remarkable number. These are patients that are already clinically sick. So in theory, if we could give this to younger patients, we could get into that pre-FEV1 concept. But what's really amazing is the sweat test data. Because every other therapy we have is just treating symptoms and complications. But what VX-770 or Kalydeco was doing, it's doing something to the basic defect. So if you look at their sweat test, this shows the change in their sweat test. So the patients who were given VX-770 basically had a decline in their sweat tests by about 50 milliequivalents per liter. There's almost a normalization of their sweat chloride, which is an incredible proof of concept. I'm going to just skip, this just shows, sorry. I'm going to skip that for a second. I'm going to skip these. It's in your thing, but okay. So the Vertex products, Vertex actually has Kalydeco out on the market. The problem with Kalydeco is, remember, it's a potentiator. It's not a corrector. And the potentiators were only a small number of patients in our CF population. Kalydeco really targets the G551D mutation, which accounts for only 5% of our patients. We are starting to expand the use. It's been FDA approved now for another mutation called R117H. And there are a series of new drugs that are coming out that are being researched by Vertex as well as some other companies that are combining, and there was a big thing in the paper the other day, looking at a combination drug for Delta 508 patients and patients who are Delta 508 in combination with another mutation. This stuff has a long way to go, but in terms of proof of concept, it's really, really a game changer. I have 2 minutes, right? Okay, 3. Okay, we're going to just sort of briefly just go through this. I'm going to skip this because I talked about it at the beginning, the gastrointestinal complications. This just shows the shriveled up pancreas that we alluded to before. In addition to the fibrotic pancreas, babies with cystic fibrosis can have rectal prolapse. Again, because they're so malnourished from not absorbing the food that when they have a bowel movement, they don't have the tissue density to actually hold their rectum in. And when they push out, the rectum actually prolapses. They can also have hepatosplenomegaly from fatty infiltration from their liver. And pitting edema, again, because of malabsorption and low protein rates. We treat their GI disease with high-calorie, high-fat diets. We also replace their enzymes that they're missing. So we have synthetic enzymes that are actually, they're not synthetic, they're actually made out of the pancreases of pigs from slaughterhouses that replace the enzymes that patients don't have. So every time these patients eat, they have to take enzyme replacement. And we also replace the vitamins, those fat-soluble vitamins, vitamins A, D, E, and K. We've gone through all of this, so I'm going to sort of skip it, and I just want to talk a little bit about newborn screening. So there is nationwide newborn screening since 2009. So the advantage of this is that every baby born in the United States is now screened for cystic fibrosis in the same way they're screened for other diseases like thyroid disease, PKU, et cetera. It's somewhat complicated because we have a pretty high rate of false positives. But the way that it's done is the immunoreactive trypsinogen is a pancreatic enzyme, and in people with cystic fibrosis, in babies, it leaks out into the bloodstream. So this is what's called a two-tier system. When they do that heel stick for PKU and thyroid disease, the state also measures the IRT. If the IRT is elevated, they then do a second-tier test, which is a mutational panel, to see whether or not the baby carries any mutations for cystic fibrosis. If the baby has a positive screen, they then get referred into a cystic fibrosis center for sweat testing. It's a very high rate of false positives because most carriers actually end up having elevated IRTs, so it's a pretty complicated system. And so I want to end with, I think that what I hope I've taken you through is this concept of we've had this disease, we've known about it for a really long time, we really didn't understand very much about it, and over the last 20 years we've learned about the genetics, we've learned, and understanding those genetics has allowed us to really explain a lot of sort of the clinical pictures that we understood. We've learned a lot more about the basic science, again, which has allowed us to understand and really explain to us a lot of the clinical pictures and the pathophysiology that we've seen. But really the beauty of that is that we've been able to translate that into therapies. And that has translated into increased survival for our patients. The median survival of an untreated patient, as I mentioned before, is 6. We're now up to about 39, 40 years of age. That includes all comers. It's really expected that a baby born today with CF should really live well into their 40s. And this number just keeps on going up and up. And I'm going to close. This is a picture of my patient, Megan, who is in college. She has not had an easy ride with cystic fibrosis. She had a gastrostomy for a long time because she couldn't maintain her weight. She has been in and out of the hospital a multitude of times for pulmonary exacerbations. She has CF-related diabetes, and she takes insulin. But she is in college, drives a great new Jeep that her dad just bought her, and she's a great snowboarder. And this is really what our patients look like today, as opposed to that skinny little, very malnourished baby I showed you at the beginning. So, right on time. Thank you.
Does anyone have any questions for Dr. Patel?
And I'm here if somebody wants to come up afterwards. Okay.
Thank you very much. That was awesome.
Anytime.
When I was a medical student in 1989, shortly after the gene had been developed,
1985,
and they said that gene therapy was going to
Such an amazing story. The gene therapy story is so interesting. It's so, because exactly. We sort of thought gene therapy would, we sort of thought that being a disaster. Not to say that it won't be an answer for mine, but the Vertex story is really, the Vertex.
Vertex is.
How are you? How's it
Good,
going in
thank
here?
you. Oh, okay.
Yeah.
Do you know, have they been putting the flash drives in here or in?
I put it in there, but I think I put it in there too.
So let's try.
No, that was awesome.
No, I'm actually not. Well, I'm on Echo right now, but like. There. There should be a separate folder.
Sorry.
There's actually a folder. You scroll down. Oh, I don't know why it's not having a folder.
This one?
Yeah. Yeah, that's it.
And how do you want to,
Slideshow, I guess.
or do you want the presenter?
Oh, is there a presenter view? And this should be awesome.
See. Yeah. I don't see it.
And I think it's just being on the map. Is it just on the map?
Yeah. No. Oops, sorry. Maybe we'll do that. View.
Is this the pointer?
I think that's just the advance. The slide advance.
Oh, okay.
Jill, do you know if this is the pointer?
Yes.
It is.
pointer should work just fine.
I look like, kind of how Pete can kind of recruit some of these, kind of hold these alveoli open. That's part of like the principle behind this, right? Is that you're kind of maintaining these open alveoli. So even at small tidal volumes, this Pete, this positive and expiratory pressure, kind of holds open and creates this bigger kind of FRC. So you have, you don't have this kind of recurrent collapse. So, other questions?
Thank you very much.
Thank you.
Yeah, so we have one last lecture. We're going to meet back here at 11 o'clock on COPD. Oh, I thought it was Christy. Oh, okay, so sorry, occupational lung disease at 11. It's
I actually had like so many slides. I was like, oh, I need to move. And then
You were not at a rush pace, though. It was good. Do you have a question for Dr. Adams?
panic.
She's the.
I hear you. I would have the same type of reaction.
You have your thumb drive power, right?
Yeah.
Okay. Let me steal your thumb drive. You want to use? Or...
Oh, they brought the next one. Next hour, sorry. Great. Oh my god. Alright. Sorry, I think I might have misunderstood it. You
Oh,
were
yeah.
asking if that was my USB or...
No. I was asking if it's okay if I put it in.
Oh, okay. I realized as you put it in that I must have misunderstood.
Where's her USB showing up?
And this one.
Oh, it's on the right. Nina, we're version 6. All right.
Can I expand it?
everyone. If you could all take your seats, we're going to get started on our last lecture of the day. I'm very pleased to present our next speaker, Dr. Neena Patel. Dr. Patel is an assistant professor of medicine in the Division of Pulmonary Allergy and Critical Care. She's also the co-director of the Interstitial Lung Disease Program, also here at Columbia, and she'll be talking to you today about occupational lung disease.
Okay. All right, so we'll go ahead and get started. I believe I'm supposed to tell you guys that I've received consulting fees and speaking fees from Boehringer Ingelheim and Intermune, which won't impact our discussion for today. So what we'll do over the next 45 minutes or so is define occupational lung disease, very briefly touch upon the epidemiology and pathophysiology of these diseases, and then we'll focus in on a few different types of occupational lung disease. Unfortunately, the scope and breadth of this topic is fairly large, so we really can't cover everything that falls under this rubric. But we're going to focus for today on occupational asthma, pneumoconiosis, and if time, we'll move on to hypersensitivity and pneumonitis and very briefly touch upon cancer. So the definition of occupational lung disease is a group of illnesses that are caused either by repeated extended exposure to an irritant or a single and very severe exposure to an irritating or toxic substance that eventually leads to respiratory illness or impairment. The diseases can be related to specific occupations, or they can be pre-existing respiratory illnesses that are worsened in the workplace. The epidemiology of these diseases, according to the American Lung Association, places the rate of occupational lung disease at 2.1 per 10,000 workers, which in and of itself doesn't feel like an extremely high rate, but if you kind of consider the New York metro area, that's about 2,000 people in this area who potentially have occupational lung disease, so also not insignificant. And I think this diagram is fairly important. It's kind of a visual depiction of why the lungs in particular are more susceptible to occupational insults than perhaps other organ systems. If you consider the mucosal membrane surface that can extend, that extends all the way from the nasopharynx through the pharynx, through the trachea, the bronchi, and all the way down to the alveolar surface, that's a pretty extensive mucosal surface that's exposed to really anything that's in the environment. In an average working week for somebody who's sedentary for about 40 hours in a work week, that's 14,000 liters of air that's exchanged through that surface. Now you take somebody who's in construction or somebody who's in a more active profession, and that increases by tenfold. So that's up to 140 or 150,000 liters of potentially toxic air, in the case of occupational lung disease, that are being exposed to that mucosal surface area. Now, in terms of where the disease occurs, it really depends on the particle size and to some degree the solubility of the particle. But it makes sense to state that larger particles are going to deposit up here in the nasopharynx, and as the particles get smaller, they'll start to deposit in the large airways, and eventually the very smallest of particles will deposit in the alveolar space. I apologize, I'm going to switch the order of the slides for a minute here from what's in your syllabus. This is kind of depicted better in this diagram of the tracheobronchial tree. And as we've already discussed, as you can see here, the larger particles that tend to be 5 to 10 microns in size can deposit around the large airways and cause asthma and bronchitic type symptoms. The more middle particles, 3 to 5 microns, cause bronchiolar or small airways disease. And then the very smallest particles, less than 3 microns in size, can deposit in the alveolar sacs and make their way into the alveolar interstitium and cause really quite significant respiratory impairment, interstitial lung disease, which you'll hear about more later in the week as a category of diseases, and you'll hear more about later in this hour in terms of the types of illnesses. So as I mentioned, we're going to focus on 3 major categories of our disease in the lecture today. The first is asthma and bronchitis, which can occur both by immunologic and non-immunologic airway hyperreactivity, and we'll delve into that a little bit later. The pneumoconioses refer to a whole group of illnesses in which essentially there's deposition of particulate matter that exceeds the lungs' capacity, specifically the alveolar macrophages' capacity to clear that dust. And the dust can do a couple of things. They can cause direct cytotoxicity to the alveolar epithelium, which sometimes can lead to carcinogenesis. They can also cause a dramatic alveolar macrophage response, which causes cytokine and fibrogenic mediator recruitment to the interstitial space and can cause ensuing fibrosis or granulomatous interstitial pneumonitis. And the last category of disease that I hope we'll get to is hypersensitivity pneumonitis. That's an allergic response to inhaled organic antigens. So pneumoconioses tend to be due to inorganic particulate matter, whereas hypersensitivity pneumonitis tends to be due to organic antigens. So we'll begin with a discussion of occupational asthma. So occupational asthma is defined as variable airflow limitation and or airway hyperresponsiveness, which occurs due to exposure to a stimulus, sometimes also called a sensitizer, basically an exposure in the occupational environment. It accounts for not a small minority, 9 to 15% of cases of adult asthma. And you can see in this table here, which is not exhaustive, that there's really a wide range of professions in which you can be exposed to sensitizers or irritants that can cause occupational asthma, ranging anywhere from people who are doing painting, farmers, as well as healthcare workers who are exposed to latex, and pharmaceutical workers who are exposed to various chemicals involved in the production of drugs. So the pathogenesis varies very much depending on which type of occupational asthma you're dealing with. So the first type that we'll discuss is called immunologic occupational asthma and accounts for the large majority, 90% of cases. And I'll refer you over here to this diagram. What happens in this case is that a high molecular weight sensitizer or antigen is inhaled. It is presented by an antigen-presenting cell, part of the innate immune system, to a CD4 T helper cell, which elicits a B cell response that results in IgE-specific antibody production to that high molecular weight antigen. What that means is that as that antibody response develops, when the patient becomes exposed to that sensitizer over and over, there is activation of those IgE-mediated antibodies, and there's recruitment of inflammatory cells every time they're exposed to the airways, which leads to airway inflammation as well as airway hyperresponsiveness. So again, that's IgE-mediated. Now, the second type of occupational asthma is non-immunologic or irritant-induced asthma, and the injury here is quite different. It's depicted over here on the right, and really what you see is direct injury to the alveolar epithelium with denudation of the typical ciliated epithelium, which leads eventually to an injury response that leads to subepithelial fibrosis and airway remodeling. That also causes airway hyperresponsiveness. This occurs in the minority of cases, about 7% of cases. It can often be even one single large exposure. That disease is specifically called RADS, reactive airway dysfunction syndrome, in which there is a large exposure that leads to damage to the epithelium and causes irritant-induced or non-immunologic asthma. This is also described in recurrent low-level exposure to some type of chemical or toxin. And lastly, there's work-aggravated asthma, which is really pre-existing asthma that is aggravated by something in the work environment. So this is the first of many tables that you'll see during the course of this talk. It's kind of a busy table, but we're just really going to focus on the first row here to begin. So not surprisingly, the different types of asthma have different clinical presentations. So those people who have immunologic asthma have a latency period. What that means is that you don't show up at work one day and have asthma the next day. What it means is that there's time that's required for that immunologic response to happen. So these patients don't develop symptoms until often several months to 1 to 2 years after they've been in a workplace and been exposed to the sensitizer. Their symptoms, not surprisingly, worsen when they're at work and improve when they're not at work. So whenever they're at work and the sensitizer causes the IgE-mediated response, they develop airway hyperresponsiveness, their peak expiratory flow drops, and they develop worsening symptoms. And when they leave work, that response kind of resolves. Now, irritant-induced asthma is quite different. These patients, again, often in the setting of a very high volume exposure, sometimes to gases such as chlorine gas, ammonia, sulfur dioxide have all been described. They'll develop that epithelial injury that we looked at in the prior diagram, and they develop symptoms almost immediately, within as early as 24 hours after the exposure. And their symptoms don't vary whether they come and go from the workplace. The epithelium's damaged, and until it heals, they're going to continue to have symptoms. So they have symptoms for up to 3 months following that exposure, and generally don't tend to have a prior history of asthma. So they do have airway hyperresponsiveness, but it doesn't really change depending on whether or not they're in the workplace. And lastly, there are the patients who have pre-existing asthma whose symptoms worsen when they're at work, who also develop worsening peak expiratory flow and symptoms when they're at work. The treatment to get to this last row here is really pretty similar across all 3 types of asthma. It's avoidance of the exposure, treatment of the asthma symptoms, and either leaving the job or attempting to minimize the exposure as much as possible. So this is summary slide number 1. There are a couple of different types of occupational asthma: immunologic, the majority; non-immunologic, the minority. The immunologic type requires a period of sensitization, whereas non-immunologic is immediate, and the keystone of treatment in both really is antigen avoidance. So from here, we're going to move on to a discussion of the pneumoconioses. And to do that, I'd like to discuss a case. This is a gentleman who saw me about a couple years ago, still follows with me actually. So 40-year-old man, really no prior medical history at all, healthy guy, found to have restricted PFTs on routine spirometry that was done at his work at Con Ed. He mentioned that he did field work, often working with electrical wiring, being up on poles and things of that sort. Also previously worked with automotive spray paint for about 15 years. His PFTs in my office demonstrated not only restriction, but obstruction as well, and he had imaging studies that were abnormal. He was told that he couldn't work due to his pulmonary disease, which he was very concerned about since this was, of course, his livelihood. So these are some representative cuts of his images. I don't know how much you've seen in the way of CAT scans, but these are axial images, or cross-sections of the lung, really. And you can see that there are a number of dots, particularly surrounding this tracheobronchial, or these bronchovascular bundles. You see a number of extra nodules or dots here compared to this area of the lung. And you see some slightly larger nodular opacities here in the bottom parts of the lung. So he has both micronodules and slightly larger nodules, so it is a quite abnormal CAT scan. And the question that we'd like to get to the bottom of over the next few slides is, what type of lung disease does he have? So to answer this, it's worthwhile for us to delve into the pneumoconioses, which encompass a broad category of diseases, and I'm focusing on some of the more common ones. So we'll begin with silicosis. Silica is not good to inhale, which you probably could have assumed even without this diagram. So silica is actually quite abundant in the Earth's crust. It's one of the most abundant minerals that exists. So it makes sense then that anything that involves disturbing the Earth's crust could potentially give you silicosis. What's perhaps a little more deceiving is that silica-containing rock or sand is used in a lot of different applications across a lot of different industries, where it's perhaps not as well known that the workers are exposed and are at risk. So pulmonary disease occurs to inhalation of crystalline silica. And as I mentioned, there are some jobs here that are not surprising where you may have silica exposure, such as mining, foundry work, sandblasting. But you can also develop silicosis in the production of ceramics, in the production of certain cosmetic products, glass manufacturing, and we've seen a number of cases develop in this area associated with dental technicians who were building molds for x-rays and whatnot. There also is a case series out of Turkey of denim workers who developed silicosis from sandblasting jeans. So it's always good to be vigilant and take a good occupational history if you're concerned about that possibility. So in regards to pathogenesis, what happens in silicosis is that there's inhalation of a crystalline silica particle, either into the alveolar space or into the interstitial space. the silica particle is picked up by an alveolar macrophage or by potentially an interstitial macrophage, and that leads to a tremendous inflammatory response with release of TNF-alpha and interleukin-1 beta, recruitment of multiple cytokines and inflammatory cells, as well as recruitment of fibroblasts to the interstitial space. So there's a mixed inflammatory and fibrotic response. Depending on the size of the particulate matter, some of that can be around the small airways, and a lot of it is further down in the alveolar space in the alveolar interstitium. The diagnosis requires a fairly convincing history of exposure to respirable crystalline silica. So this is where the history in your history and physical portion becomes very important. It requires abnormal chest imaging, and it requires exclusion of any other etiologies for the abnormalities on the imaging. So here's another table, one of two in our discussion of silicosis. So silicosis is fairly well studied, and the clinical manifestations of this disease are varied and very well described. So we'll begin with one form of silicosis that's called acute silicosis. This is characterized by a briefer exposure than some of the other forms of silicosis, a few weeks to up to 5 years. The time of onset, also called the latency period, is fairly brief. This can occur within 1 to 3 years, acute silicosis. The presentation can be fairly nonspecific with cough and shortness of breath, but patients can also develop constitutional symptoms like fevers, sweats, general malaise, and just ill feeling. Accelerated and chronic silicosis are the same radiographically and pathologically, and really only differentiated by the time to onset. So accelerated silicosis occurs with often less than 10 years of exposure, and with a latency period that's also less than 10 years, whereas chronic silicosis occurs over decades of exposure and with a latency period that's also 10 to 30 years later. Patients in both categories can present with fairly nonspecific symptoms such as chronic cough and dyspnea. Patients with accelerated silicosis are felt to have perhaps an exaggerated immune response to the silica particle, and will often develop autoantibodies and develop autoimmune disease. So they may develop arthralgias and true autoimmune disease such as rheumatoid arthritis or Sjogren's syndrome in association with their silica exposure. In both cases, as I mentioned, because the particulate matter can be inhaled at the level of the bronchioles as well, you can develop an airway-based component to the disease as well as a restrictive component from the interstitial process. And the last form of silicosis is called progressive massive fibrosis, which is basically an end stage of silicosis. It develops with significant amounts of exposure, a significant latency period, and is characterized by progressive shortness of breath, often respiratory failure, as well as cor pulmonale, which is right heart failure associated with the lung failure. So this slide really focuses on the radiographic and pathologic manifestations of these different forms of silicosis. So as you can see, I've combined chronic and accelerated because they present, again, radiographically and pathologically in a similar fashion. They're also sometimes referred to as simple silicosis, whereas progressive massive fibrosis is sometimes referred to as complicated silicosis. So the acute form of silicosis presents with an alveolar filling process. It can sometimes be accompanied by intra and intralobular septal thickening, but really the process is a haziness that we'll look at in the next slide through the alveolar space. And when you biopsy these patients, their alveoli are full of PAS, periodic acid shift positive material, lipoproteinaceous material. And really what that material is surfactant that's failed to be degraded because the alveolar macrophages have been completely overwhelmed by the sheer quantity of silica that's been inhaled. So the alveolar macrophages fail, and as a result, they don't break down surfactant, which is part of their typical responsibility. So it's an example of too much of a good thing, actually. So simple silicosis presents with small nodules, 2 to 6 millimeter nodules that tend to be upper and posterior predominant in their location. These patients will often have lymphadenopathy, and they'll also have characteristic eggshell calcifications, which are not pathognomonic for silicosis, but are kind of a supporting feature. The nodules radiographically under a microscope are called silicotic nodules and again have a very characteristic appearance. Basically, there are weakly birefringent particles that are in the middle of whorls of collagen, which are surrounded by a rim of inflammatory cells. What birefringent means is that if you put these slides under a polarizable microscope, they basically kind of light up. And that's a good indication that this patient has indeed had an exposure to a particulate matter consistent with the silica or silicate type family. And lastly, you have progressive massive fibrosis, which really is a coalescing of these smaller nodules into mass-like opacities that are often greater than a centimeter. They sometimes have central necrosis. They're so large that they physically occupy the upper portions of the lung and pull the structures in the hyla upward, causing most of the lower lobes to be hyperinflated because all of the ventilation is just going to the lower lobes. And here are some pictures of what this looks like. So this is acute silicosis. As I mentioned, this is an alveolar filling process. So you see that these lungs have a lot of gray where there should be a lot of black. And that's, again, that accumulation of surfactant in the air spaces. This is a chest x-ray of a patient with simple silicosis. You can see a diffuse profusion of micronodules. And you can see axial or CAT scan views that show, again, innumerable micronodules throughout the lung fields in the setting of simple silicosis. So our patient didn't have quite this many nodules, but he did have a lot of nodules. So silica or silicosis is certainly on the differential for what he had. And this is a patient of mine who unfortunately passed away from progressive massive fibrosis. You can see here that he had these mass-like opacities, again, literally occupying huge portions of his lung and pulling the hilar structures of the lung upward. This is what it looked like on CAT scan or axial views over here. And he died of both progressive respiratory failure and cor pulmonale associated with progressive massive fibrosis. And pathologically, these are what these areas of progressive massive fibrosis look like on gross path. Again, massive space-occupying lesions. This is a silicotic nodule, so this is a high-power microscopy in which, again, you see this whorled, almost onion skin-like collagen, which is surrounded by this rim of lymphocytes or inflammatory cells. And this is what it looked like under polarizable light. So this is a patient who had mixed dust pneumoconiosis. So this kind of clinches the diagnosis. When you see this particulate matter, you know that this is due to a foreign body inhalation as opposed to an infectious insult or some other inflammatory process in the lung. There are well-described complications of silicosis due to the significant macrophage dysfunction. These patients are at significantly increased risk of tuberculosis, about threefold higher than the regular population. As I mentioned, some patients have a very significant immunologic response to the silica particle and will develop autoimmune disease, including scleroderma and Sjogren's syndrome, as we've discussed. Some patients will have larger airflow obstruction as opposed to the more distal deposition that we've discussed. And these patients who have silicosis are at increased risk for lung cancer as well. The treatment is unfortunately pretty limited. You can try corticosteroids, which often will lead to some symptomatic benefit, but don't lead to longitudinal improvement in lung function. Whole lung lavage, which is literally washing the lungs out in the operating room with 10 to 11 liters of saline in the setting of acute silicosis, trying to wash out all that particulate matter, is variably successful, but not consistently so. Lung transplantation really is the treatment of choice for people who have progressive respiratory failure, and of course prevention is key. Silica inhalation can be prevented with a high-grade respirator mask. Unfortunately, as you might imagine, in many parts of the developing world, as well as in this country, many people don't use this type of protection. So summary number 2 is that silicosis can occur in any occupation that involves consistent inhalation of crystalline silica. Silicosis may present in varying forms, including acute, accelerated/chronic or simple silicosis, and progressive massive fibrosis, also called complicated silicosis. The pathologic hallmark of this disease, or of simple silicosis, is the silicotic nodule, and treatment options are limited. This is one slide and the only slide I'm going to show you on coal workers' pneumoconiosis. Cold-workers pneumoconiosis looks radiographically very similar to silicosis. However, histopathologically, it looks quite different. Rather than having silicotic nodules, these patients have what are called coal macules. So they have pigment-laden macrophages due to ingestion of coal with ensuing recruitment of inflammatory cells and formation of nodules, similar to the idea behind the silicotic nodule, except with coal macrophages at the center of it. You can see here on Grosspath that the lungs are literally full of coal. They're black. And you can see microscopically that they develop granular black areas of lung. Cold-workers pneumoconiosis patients can develop simple and complicated forms of disease, very similar to those patients who have silicosis, and they're also, again, at increased risk of tuberculosis. So we'll move on now to asbestos. This is a picture taken from Wikipedia of asbestos fibers. They're kind of interesting looking fibers. And the term asbestos is literally derived from the Greek word for inextinguishable. And this really refers to the properties of this mineral. So asbestos is highly heat resistant, so not combustible, and also has great tensile strength. So dating back to Greek and Roman times, asbestos has been used for various applications, including, of course, construction and insulation in more recent times. There are two major fiber types, which we'll get into a little bit later, amphibial fibers and chrysotile fibers. And the type of fiber is actually relevant in terms of what type of disease a patient may develop or how significant disease they may develop. So as mentioned, asbestos has been used in many different applications over the years due to its properties as a very strong and heat-resistant fiber. It's been used in pipe fitting, carpentry, construction work, and shipbuilding as kind of some of the more common professions, as well as in the rail yards. And asbestos can cause a number of different manifestations in the lung. So asbestos can cause parenchymal disease, which is called asbestosis, so that means disease affecting the lung tissue. It also has well-known pleural manifestations and also can cause an increased risk of malignancy. It increases the risk of primary lung cancer and has been associated heavily with mesothelioma. So the first published reports of asbestos lung disease were in the 1920s, but there's actually an interesting literature. Pliny the Elder, a Roman historian, described slaves who used asbestos to weave into cloth as developing respiratory ailments. There are also some reports in Greek literature as well. So it seems that back dating quite a while ago that many people realized that there was an association between asbestos and respiratory illness. But again, good published literature started emerging around the 1920s. So what we know is that there is a dose-response relationship with asbestos exposure. So not surprisingly, perhaps the more that you inhale, the greater the risk of lung disease. Now, as I mentioned, the fiber type impacts lung deposition and disease. So these straight fibers, amphibial fibers, of which crocidolite is one of them, deposit more distally and also are less kind of amenable to removal by normal mechanisms in the lung. So the ciliated epithelium is less effective at basically removing these amphibial fibers than they are the chrysotile fibers, which are more curly and described as serpentine. So these tend to deposit less distally and tend to be somewhat more degradable than the amphibial fibers. The latency period tends to be pretty long, similar to some of our silicosis patients. So patients can be exposed for years, but really won't develop disease until decades later. And while we know that there are many health and risk factors associated with asbestos exposure, there are still many sites of ongoing major production, including in Russia and China, as well as South Africa and Australia. I think asbestos use in the U.S. is more regulated, certainly, than it used to be. So the mechanism of injury in its most basic form is exposure injury with ensuing fibrosis. In terms of what happens, similar to some of the other particulate matter we've discussed, asbestos is inhaled by and phagocytosed by macrophages, or basically eaten up by macrophages, in which there's an ensuing inflammatory and fibrotic cytokine release. However, there's a different component to the disease in asbestosis that is quite relevant to the pathogenesis of fibrosis in this disease, which is that there's mitochondrial injury and there's endoplasmic reticular stress. And these two events lead to reactive oxygen species production and alveolar cell apoptosis, which is felt to be a pretty sentinel event in why these patients develop a very fibrotic response rather than inflammatory response. So with the alveolar cell apoptosis, you have a couple things. A, you have a gap in the alveolar capillary membrane, and B, you have recruitment of growth factors and myofibroblasts specifically to that alveolar epithelial interface. Myofibroblasts are very effective at laying down collagen and recruiting other cells like themselves. And so asbestosis patients don't have an inflammatory response in the lung. Their response is really purely, for the most part, fibrotic. So the diagnosis of asbestosis requires a history of asbestos exposure. It requires characteristic high-resolution CT findings, which we'll review. For patients who undergo an alveolar lavage or a lung biopsy, you want to demonstrate an increased presence of asbestos fibers or asbestos bodies, which are also called ferruginous bodies. Those are basically fibers of asbestos that are coated by a coating of protein and iron. Bilateral pleural plaques are very typically seen in asbestosis patients, and it's important to note that all those pleural plaques indicate is that the patient has had exposure to asbestos. They're just corroborative of that history. They don't lead to causality. So a person can have pleural plaques and not have asbestosis. However, someone who has asbestosis should have pleural plaques. So I think we're kind of nearing the last of all the tables. This might be the last one, actually. So there are, again, a couple of different ways in which asbestos can affect the lung. We'll begin with the lung tissue or parenchymal disease, which is called asbestosis. So these patients can present with just insidious cough and shortness of breath. As I mentioned, they have a fibrotic, not an inflammatory response in the lungs, so their PFTs tend to be purely restrictive. They don't have an obstructive component to their disease at all. And their high-resolution CT shows findings consistent with a UIP, or usual interstitial pneumonitis pattern. You're going to be hearing more about that later this week in your interstitial lung disease lecture. But what a UIP pattern consists of on a chest CT is a lower lobe predominant subpleural or peripherally based pattern of interstitial markings that tend to be linear. So we looked at patients with silicosis who had a lot of nodules. Patients with asbestos tend to have increased lines, not nodules. They also can have parenchymal bands and inter- and intralobular septal thickening. They can develop what's called honeycomb change, which are basically cysts that are separated by interlobular septae, and they represent areas that are actually physically destroyed lung. On biopsy, for those patients who have a biopsy, they have usual interstitial pneumonitis histology, which is abbreviated UIP, and again, an increase in asbestos bodies. Now, the pleural disease manifestations, while many, are interesting because these patients tend to be asymptomatic with their pleural manifestations. So pleural plaques, again, indicate asbestos exposure, but don't really cause any symptoms. They tend to be seen on the parietal rather than the visceral pleura and on the 6th to 9th ribs, and frequently over the diaphragmatic pleura. On lung pathology, these are really acellular collagen bundles that have a characteristic basket weave pattern. Pleural adhesions are points of pleural inflammation and fibrosis in the pleural surface that lead to rounded atelectasis. So basically, these little areas of inflammation and fibrosis cause so much tension on the pleura that they pull the adjacent lung into a little ball, which is called rounded atelectasis and can often resemble a cancer or a mass-like opacity. And lastly, benign asbestos-associated pleural effusions are inflammatory exudative effusions, can have actually a short latency period. So the one manifestation of asbestos exposure that can occur within 10 to 15 years of exposure. They're unilateral and generally tend to resolve spontaneously, but on some occasion can lead to pleural thickening. And so these are some pictures of some of the things we've been talking about. This is a UIP pattern on a CAT scan. I'm not going to belabor it because, again, you're going to see more pictures of this later this week. But you can see that instead of the nodules that we saw on the patient with silicosis or my patient, you see a lot of extra lines, and that's really the biggest abnormality. And those extra lines tend to be out on the edge of the lung. You also can see these areas where there are holes in the edge of the lung, and those are the areas of what's called honeycombing. Here you see this rounded opacity, which almost looks like a mass. That's rounded atelectasis caused by pleural adhesions and pleural inflammation. What differentiates it from a mass is that it has this classic comet tail, which is the bronchovascular bundle that's emerging that tells you that really it's an area of collapsed lung and not actually a lung mass or a cancer. And lastly, here are some pleural plaques which calcify in 5 to 15% of people over time, and they're just these elongated areas of kind of, again, collagen deposition in the pleura that can become calcified in some people. So as I mentioned, asbestos does increase the risk of primary lung cancer significantly. It increases the risk 6-fold in non-smokers. There's a dramatic synergy with tobacco and asbestos exposure that increases the risk up to 60-fold in non-smokers of lung cancer, in smokers, of lung cancer. And this is a patient who has malignant mesothelioma, of which there is a strong association with asbestos exposure. You can see on the chest radiograph that this patient's tumor lung appears to be encased by something, and on gross pathology you can see that that's a tumor, this massive mesothelioma, which is a pleural tumor literally encasing the lung. Here's a picture of an asbestos body. It's also called a ferruginous body, and again, this material here is an iron and proteinaceous coating over an underlying asbestos fiber. They're characteristically described as having a dumbbell shape, which I think you can kind of appreciate on this slide. And these are what pleural plaques look like on gross pathology on the diaphragmatic pleura of an autopsy specimen of a patient with asbestosis. So summary number 3 is that asbestos inhalation can cause pulmonary parenchymal disease and pleural disease, as well as an increased risk of malignancy. Asbestosis is the pulmonary manifestation or pulmonary parenchymal manifestation of asbestos exposure, characterized by UIP both on CAT scan and on lung pathology, with ferruginous bodies being a hint that the UIP is in fact due to asbestos exposure rather than another etiology. The pleural disease manifestations are many, as we've discussed, and tobacco and asbestos are very synergistic in increasing the risk of lung cancer. There's no known treatment for asbestos-related lung disease other than lung transplantation, unfortunately. And so with that, we're going to move on to beryllium. So beryllium is element number 4, as you can see here. It is lighter than aluminum, but stronger than steel. So perhaps not surprisingly, it's used very commonly in the aerospace and defense industries. So these professions that you see here on the left are common industries, especially these first 3 that are associated with beryllium exposure. But similar to silica, beryllium has many different applications due to its very light weight. And so it's also used in electronics and computer manufacturing. It's used, again, by dental technicians, also used by machinists and welders, as well as ceramics workers. So, beryllium can be more prevalent, or exposure to beryllium can be more prevalent than we might think initially. The mechanism of injury in berylliosis is actually quite different than some of the other pneumoconioses, and quite interesting. So patients inhale beryllium, and again, it's phagocytosed by a macrophage. And again, there's a CD4 T helper cell that binds to that macrophage, and a response is elicited. But the response which is elicited is a cellular-mediated immune response. So these patients actually develop beryllium-specific CD4 T helper cells. And every time they're exposed to even small quantities of beryllium, they have a dramatic proliferation of these T helper cells, which leads to a granulomatous reaction in the lung. So these patients develop a granulomatous interstitial lung disease with the formation of non-caseating or non-necrotizing granulomas that's very difficult to distinguish from something called sarcoidosis, which I don't know if you've really heard about yet in your lectures to date. So patients have an immunologic reaction to beryllium who develop berylliosis. The diagnosis requires an exposure to beryllium. So this bears in mind because, as you'll remember, my patient was a Con Ed electrician who had a lot of exposure to wiring and had micronodules on his CAT scan, raising concern for me that he could have silicosis or possibly berylliosis as well. So how do you distinguish these possibilities? One way is that you can do a beryllium lymphocyte proliferation test. And what that involves is taking the patient's blood and literally combining it with 3 different concentrations of beryllium and measuring how much the T cells proliferate. So patients who have a beryllium lymphocyte proliferation test that returns positive have a very high likelihood of having borreliosis. The specificity of this test is very high. Unfortunately, the sensitivity is fairly low, so the negative predictive value of a BELPT is not really quite as good. It can be improved by repeating it 2 to 3 times. And these patients, again, have non-caseating, non-necrotizing granulomas on biopsy. There are no foreign bodies that you identify under polarizable light. The granulomas are indistinguishable from granulomas that you would see in a patient with sarcoidosis. So the diagnosis in these patients really is very contingent upon a very good exposure history as well as a positive serum test. So the symptoms, similar to many of the things we've discussed today, can be very insidious. It can be just a dry cough, shortness of breath. Some people feel systemically ill. They have fevers. They feel generally unwell. The latency period is briefer than some of the other diagnoses we've discussed so far. It can be as brief as 3 months to up to 30 years. These patients can have crackles on their lung exam. They can also develop cutaneous nodules, so they can develop granulomatous inflammation if they've touched beryllium dust under their skin. And they can also develop, as opposed to some of the other diseases we've talked about, extrapulmonary manifestations of their disease. So even though the inhalation is in the lung, they can actually develop granuloma-associated hypercalcemia, granulomatous inflammation in the liver, and kidney stones as well. Their pulmonary function studies do tend to have an airway-centered component as well as an alveolar component. So they tend to have mixed obstructive and restrictive PFTs and can have a gas exchange impairment as well. So their imaging also looks very similar to patients who have sarcoidosis, another granulomatous interstitial lung disease. They can have hilar lymph node swelling, so that's called hilar lymphadenopathy. You can see here that the lymph nodes look a little, or the hyla look very prominent, and that's due to lymph node swelling. On CAT scan, they tend to have a profusion of nodules, similar in some ways to the patients we saw with silicosis. Sometimes these nodules can form scar-like opacities, and in the advanced stages, these patients can develop fibrosis on honeycomb change as well. And this is what it looks like under pathology. They develop non-necrotizing granulomas, of which you see clusters here, which are made up of inflammatory cells and multinucleated epithelioid histiocytes. So the treatment is avoidance of beryllium. Because these patients don't necessarily have a dose-response relationship, because they have this very strong immunologic response, and even small amounts of beryllium can cause a tremendous reaction, it's really very important that they're no longer in a workplace where they might be exposed to beryllium. They can be treated with corticosteroids, which leads to a transient benefit in terms of symptoms, may even lead to transient benefit in lung function, but it has no long-term benefit in regards to disease progression. The prognosis is variable. There actually is a pretty significant mortality rate associated with borreliosis of up to 35%, which depends somewhat on the duration of exposure and the degree to which the patient is sensitized. And that varies by individual. Some patients will have a more dramatic sensitization to beryllium than others. So summary number 4 is that borreliosis is caused by T-cell specific reaction to beryllium that leads to non-caseating granuloma formation, which is radiologically and pathologically identical to sarcoidosis. So the history is, again, the major factor, as well as the beryllium lymphocyte proliferation test that distinguishes these two. Steroid therapy can be considered for treatment. So it looks like we have a few minutes. I'm going to kind of go through hypersensitivity pneumonitis fairly quickly. This is another granulomatous interstitial pneumonitis. These granulomas, as we'll look at in a couple slides, tend to be loosely formed granulomas as opposed to the tightly formed granulomas of sarcoidosis or borreliosis. It's due to inhalation of organic antigens rather than inorganic antigens, which is what a lot of our talk has focused on up to now in regards to the pneumoconioses. Patients can have an acute presentation or subacute and chronic disease. The acute patients have a pretty fulminant presentation. They're exposed to an organic antigen, they have a dramatic response, they feel like they have flu-like symptoms, and their CAT scan tends to show diffuse ground glass opacities and a profusion of small nodules. The subacute and chronic patients have a much more insidious presentation. They tend to worsen over weeks, sometimes months. They can have nodules, but they will also begin to develop reticular or linear changes and fibrosis over time. The response or the immune mechanisms are not super well understood, but some patients inhale an organic antigen and just develop immune tolerance, whereas others, likely due to some combination of genetic and environmental factors, develop an alveolitis and eventually develop granulomatous inflammation, which can again progress to fibrosis if they continue to be exposed to the antigen and are not treated. This is a very large and busy table, and it's not meant to be memorized by any means. Really, what it is a list of the many, many things that have been associated with hypersensitivity pneumonitis. There are some interesting ones here, like shower curtain disease, which is kind of alarming, as well as cheese washer's lung. It's good you're all in med school. Hopefully you won't get any of these. So the diagnosis depends on a very good exposure history. So I did say that in joke, but actually, as I see these patients, this is one of the more common diagnoses that I see, and it's shocking the number of places you can be exposed to mold, mold-like antigens. If we just go back to this table, without even reading it really closely, you'll see that a lot of the terms begin with moldy. So molds are a common source of hypersensitivity to pneumonitis, as are avian antigens. So not having a bird is also highly advisable in regards to this disease. And you laugh, but I've had little old ladies cry, literally sob, when I've told them they have to get rid of their birds. It's very sad. So taking a good exposure history is very important. You can check a hypersensitivity panel, which assesses for IgG antibodies in serum that are associated with exposure to mold or avian antigens. Unfortunately, these panels tend to have both high positive and high false positive and high false negative rates. So they don't really clinch the diagnosis. They just kind of support it. We've talked about some of the CAT scan findings already, and we've already discussed that the biopsy shows loosely formed airway-centered granulomas. Not surprising that they're airway-centered. This is an inhalational type disease, so the granulomas tend to be very focused around the airway. And they're in chronic forms as an interstitial lymphocytic infiltrate. So this is a patient with acute silicosis. You can see, again, more nodules than you could possibly count throughout the lung fields. This is another person with acute silicosis who has ground glass opacities and something called mosaic attenuation, which are areas of black lung alternating with areas of grayer or whiter lung. That is reflective of small airways obstruction from the lymphocytic infiltration and granulomatous infiltration. And on biopsy, these patients have loosely formed granulomas surrounding the airways. It may be difficult to appreciate, but if you kind of think back to that borreliosis slide, these granulomas really aren't quite as round. They're not quite as well formed. They're a little more spread out. So as we discussed, HP can be associated with a number of occupational and actually domestic inhalations. Acute disease presents with diffuse ground glass and central lobular nodules. And lung pathology shows these loosely formed non-caseating granulomas. You can use steroids for treatment, but again, similar to some of the other things we talked about, they're somewhat temporizing and don't ultimately change the outcome of the disease in the data that we have. So back to our case, I felt that I didn't have enough based on my history to give this man a diagnosis, so I sent him for bronchoscopy. He underwent transbronchial lung biopsy and lymph node aspiration. He had non-caseating granulomas. Under polarizable light, he had no foreign material, so we were able to rule out silicosis. He underwent a serum beryllium lymphocyte proliferation test that returned negative. So we gave him a diagnosis of sarcoidosis, but I will tell you that due to the low sensitivity of the BELPT, I am having him come back to repeat it at some point, and have strongly advised him to not be in the field and continue to be exposed to the electrical wires. So I think he's relocated to a desk job. He's actually heeded my advice, which most people don't, including Dr. Atkinson and Dr. Pullman. Okay, I think we're not going to say a lot about lung cancer. There are a lot of exposures there in your packet that are associated with lung cancer. This slide I think I was asked to do, and I'm really also not going to go through it in any detail, but you have it in your packet. And I'll take any questions if you have any. Oh, sorry. Here, I'll just come over there. Oh, thank you.
See you tomorrow.
So do you know what you're doing tech-wise
Not
here?
yet. No,
Okay.
just give me a moment.
Oh, I'm not rushing you, I'm just...
Hi.
Will you be
Are you
using
the
this?
Yes, I will be.
I am for the last class, but I can help you if you need it.
Okay, great. You just tell me. Presentation. Okay. So how can I get that?
Oh, can you? We'll do it here.
Laptop. Okay. Good.
And if you want to use the pointer, you just have to put yourself into presenter view. And then it should work just fine.
All right. Where am I
It's not
supposed to-
responding?
No.
Good night.
Yeah, go ahead. Yeah, okay. Isn't there supposed to be a little...
Oh,
And
right,
back you-
of course, because
Sorry,
you moved it. You're using your laptop, so we have to connect it here. Good point. Good catch.
Good.
Perfect.
Okay.
Will you be using
Yeah,
the
my
movie?
voice is pretty weak. Like,
So when you're ready, you'll just flip it mute. So right now it's on mute, and when you're ready, you'll just take it off of that. And it works a lot better probably on the left side.
yeah, because that's the way I face the screen. Good. Okay. Good. Thank you very much for your help.
Well, they have a lot of learning and stuff still going on there.
A lot of NVR TV.
The next year.
A lot of NVR TV that nobody acknowledges exists.
Really?
There's a lot of this person thought they lost the follow. They probably they're probably getting better and they they died from drugs for giving them more thing.
Do you have a strong interest in TV?
Yeah, I'm pretty interested in it.
You should think about reaching out to Neil Schluter or Max O'Donnell. Have you done that?
I know I haven't.
If you're interested in, as you kind of move along,
Yeah.
Max O'Donnell is a TV researcher who does TV research in critical care, and Neil Schluter is the division chief of pulmonary medicine, also has an appointment in the School of Public Health, and he has done a lot of global TV consortium.
And are they working on like clinical stuff or basic science or?
So Max, I think, is working on maybe translational versus basic science. I'm not sure which one. Neil does a lot more work with like TV clinical trials consortium and that kind of stuff. Yeah, and he partners with people various ways. So if you kind of continue to see that being an area of interest, you can come to the people who are connected.
Thank you so much.
Yep.
Feel free to sit as close as you'd like. We don't bite. Okay.